The Medical Recording Services of the College of General Practice of Canada today brings you Dr. John Pond, provincial hematologist for New Brunswick, located in St. John. Dr. Pond is certified in medicine and pathology by the Royal College of Physicians of Canada and is a member of the Royal Colleges of Physicians of London and Edinburgh.
Thank you. Good morning. It's a pleasure to be here this morning and talk briefly on a subject in hematology. And I want to consider this morning one of the subjects which comes up most frequently here in the Maritimes, and that is pernicious anemia. Going through our cards of the cases which come to us over the last 3 years, the type of hematology referred to us here in St. John predominantly consists of two types of diseases, pernicious anemia and cases of purpura, and I wish to consider the first type of condition this morning. Here in the Canadian Maritimes, pernicious anemia is very common. In fact, throughout Canada as a whole, pernicious anemia is one of the most common hematological diseases. This is also true in England and Ireland and Scandinavia. It's interesting to note in Hebbert's monograph on pernicious anemia that down in New York City, where the total is admittedly lower than here, 10% of their hematology workload also consists of cases of pernicious anemia. He makes the point that in the English-speaking population, of the total megaloblastic anemias, pernicious anemia is the most common, whereas in the Puerto Rican population of New York, the malabsorption syndrome producing folic acid deficiency is the most common. Also to be remembered is that pernicious anemia runs in families to a very great degree. Murphy's book has a beautiful case of a family of 6 generations, in which each generation had several members suffering from pernicious anemia. We recently have had a case of 2 twin sisters in their late 40s, both of which developed pernicious anemia about the same time. Modern tests have shown that many of the relatives of people suffering from pernicious anemia also have markedly lowered absorption of vitamin B12 into their systems, although the majority of these never develop pernicious anemia in its full-blown form. There are other types of megaloblastic anemia due to vitamin B12 deficiencies. Fortunately for us in Canada, these are rare. In other parts of the world, however, they are common. For example, in Finland, 25% of the population have been calculated to suffer from anemia due to the fish tapeworm disease. During the late Second World War, when economic conditions were hard on the Finnish soldiers, many of these soldiers developed severe anemia due to infestation with this tapeworm. In India, Macedonia, and Malaya, nutritional megaloblastic anemia occurs due to vitamin B12 deficiencies. Especially is this true among strictly religious people in India who have rules against animal protein ingestion. A few similar malnutrition cases occur in England among food faddists, and these are known by the name of vegans. In fact, this became so serious in Great Britain that the government decided to register this group of people to make sure that they were given the proper diet. These food faddists do not eat any form of animal protein, and this includes meat and eggs. Because of this, they eat no vitamin B12 in their diet at all, because vitamin B12 is solely contained in these foods, and they developed a striking megaloblastic anemia exactly identical in type to pernicious anemia. Perhaps we should consider for a few minutes the physiology of vitamin B12 absorption into the body. As I've said, this occurs in the animal protein foods, and we only need small amounts of this in our daily diet, approximately 1 microgram per day. This is combined in the stomach with this interesting fact, intrinsic factor. A great deal of research is being done on what the nature of intrinsic factor is, but nobody really has yet been able to isolate it. All we know is that it extracts the vitamin B12 from the protein foods and binds it in a specific manner. It then passes down in this combination through the small intestine and is not disturbed at all by the juices of the stomach or small intestine to the lower ileum, where the combination is adsorbed to the intestinal mucosa. For this purpose it needs calcium. Somehow or other, a chemical change takes place within the mucosa, whereby the intrinsic factor is detached and got rid of. The pure vitamin B12 then circulates in the blood in conjugation with the serum proteins and is stored mainly in the liver, where the total liver stores are approximately 2,000 micrograms. Therefore, any disease of the lower ileum, such as massive surgical resections, blind loops, diverticulae, will similarly produce pernicious anemia very similar to the Addisonian type. The clinical picture which these patients presents has varied very markedly in the years. If you read Addison's monograph in 1855, you will see that he talks at great length about these people who were practically all over 40 as having fever and jaundice and splenomegaly and a burning, sore tongue. In addition to the neurological, these symptoms and signs have disappeared over the years. Recently, Professor Davidson in England did a survey and showed quite well that the changes presenting in people with pernicious anemia have altered considerably. For example, the burning tongue syndrome in pernicious anemia is now a very great rarity. The presence of fever and marked splenomegaly is not seen nearly as commonly as it used to be. This is no doubt due to the fact that the population is much more aware of early symptoms and comes to the doctor earlier, and similarly too, the much greater use of multivitamin preparations, many of which unfortunately contain small amounts of folic acid and vitamin B12. Our common tonic, malt Levol 12, contains small amounts of vitamin B12. Many people will say that these small amounts are not enough to affect the clinical history and course of the disease, but unfortunately this is not necessarily true. Recently we had a case in hospital here where 2 days prior to bone marrow an intramuscular injection of vitamin B was given to the patient. This completely altered the bone marrow because it contained a small amount of folic acid, and the doctor was not aware of this fact. In the main today, the patient with pernicious anemia presents with the general symptoms of anemia. They are no different from any other type of anemia, and one should not attempt to make a diagnosis of pernicious anemia on the basis of the story alone. The one thing that is true is that folic acid deficiency does not produce the central nervous system changes that vitamin B12 does. The usual symptoms then are shortness of breath, weakness, paresthesia, and sometimes this lemon yellow color of the skin. It's very rare for cases of pernicious anemia to lose weight. The general story is that they are obese, they have this waxy glow to the skin, and sometimes this lemon yellow tinge. There is one aspect of the presentation clinically in pernicious anemia which is sometimes overlooked, and that is the mental changes. Quite a few cases who are admitted to mental hospitals as suffering from organic psychoses actually suffer from pernicious anemia. Many years ago, myxodematous madness was recognized as such. Today, perhaps, one should look again at cases of psychosis and some of the neuroses to see if some of these people are suffering from vitamin B12 deficiency. Let me give you a partial list. Moodiness, confusion, agitation, depression, going on later to delusions, hallucination, psychoses, and even epilepsy. In his monograph, Hebert has two interesting cases of psychosis with normal hemoglobins who were found on examination of the peripheral blood, followed by more complicated test, to be suffering from vitamin B12 deficiency, and their psychoses were cured by the appropriate treatment. Similarly, the peripheral nerve changes should be thought of too. Paresthesia, tingling, numbness, and coldness, first affecting the feet and later the hands. This is usually symmetrical. It moves up the limbs in a symmetrical fashion, and very often the patient will come along complaining of a tight, constricting feeling round the waist with stabbing, lightning-type pains in the calves. At other times he comes along complaining that his legs feel heavy, he has difficulty in walking, he tends to stumble, and this may bring him to hospital even though he has been anemic for many years. It is an interesting fact that many new patients with pernicious anemia come along for diagnosis when their hemoglobins are somewhere between 25 and 30%, being completely unaware that there is anything wrong with them except for the shortness of breath and these neurological symptoms which they have described. On physical examination, then, one looks to examine the central nervous system, and the things one looks for are loss of vibration sense in the feet, loss of position sense in the toes, ataxia as manifested by Romberg's sign, and then the glove and stocking anesthesia affecting all forms of superficial sensation. Loss of vibration sense can best be detected with the 256 vibrations per second tuning fork. Changes are shown by this earlier than with the 128 vibrations tuning fork. Position sense is first lost in the index toes and not the great toes. Other modes of sensation are tested in the usual way. Occasionally you see a case presenting with bruising. Examination of the fundus of the eye sometimes shows considerable hemorrhage into the retina. This is due to the fact, of course, that the platelet count is very low. The lemon yellow color of the skin is due to the raised serum bilirubin, which is usually around 1 mg%, is due to the fact that pernicious anemia is partially a hemolytic anemia. Similarly, on lab testing, one may be confused by the fact that the empirical liver function tests may show slight fluctuating abnormalities. Gallstones should be looked for, as gallstones are a complication of pernicious anemia. Similarly, pernicious anemia occurs more commonly than usual in people with myxedema and also, apparently, diabetes. This is a very interesting phenomenon and may be related to the immunological basis which sometimes seems to be present in cases of pernicious anemia. As I've said, the symptoms of pernicious anemia are those, in the main, of any type of anemia, and unfortunately, the diagnosis rests with the laboratory. For this reason, it is essential to avoid preliminary blunderbuss or multivitamin therapy. 2 years ago, we had a case which had blood transfusions to the extent of 2 bottles of blood 60 days before bone marrow was taken. This was enough to disturb the bone marrow so that a diagnosis of megaloblastic erythropoiesis could not be made by several consultant hematologists to which the case was referred in major centers of Canada. Any previous therapy of this sort, extending up to a period of 3 months, will put the diagnosis off and may affect the patient for his lifetime. First of all, the peripheral blood picture is of an anemia with a leukopenia and with a platelet count which is usually somewhere between 60,000 and 100,000. A smart laboratory technician may notice the presence of hypersegmented polymorphs in the peripheral blood and macrocytes which are often oval in shape. The specific diagnosis is made by the bone marrow. In an untreated case of pernicious anemia, a bone marrow should always be done. A diagnosis should never be made from macrocytosis in the peripheral blood. Sometimes, unfortunately, when the hemoglobin is higher than 10 grams, a bone marrow does not show definitive changes. In those cases, we have to rely on the more modern Schilling test or other radioactive isotope tests. We have found in certain cases that the Schilling test cannot be helpful. In elderly people being examined as outpatients, unfortunately, they do not always bring back the full 48-hour urine sample. This is unfortunate, and equally unfortunate is the fact that they do not tell us of this fact. Similarly, even slight degrees of renal disturbance manifested by a raised BUN make the test inadequate. Diarrhea and vomiting similarly can put the test off. For these reasons, a borderline test should be treated with great caution and should be repeated in 6 weeks to 3 months' time. Usually, in cases of pernicious anemia, there is no absorption of the radioactive vitamin B12 at all. A normal absorption is expected to be somewhere above 8%, but we have seen normal people absorbing above 3 to 4%. As I've said, the relatives of people with pernicious anemia sometimes absorb less than normal, and this does not necessarily mean that they are going to suffer from pernicious anemia later on. The Schilling test is a very valuable test, especially where previous therapy has been given or the hemoglobin is above 10 grams per cent. In our hands, the serum B12 level estimation has proved very cumbersome. It does not tell us anything which the Schilling test and the bone marrow do not tell us, and therefore we do not perform this as a routine test. Another test which is frequently considered in these people is gastric analysis, and I would like just to say a few words about the fallacies of gastric analysis. The ordinary gastric analysis, as you know, is done with a tube, and this frequently disturbs the picture. Unfortunately, 15% of people, normal people, between the ages of 40 and 60 have complete achalaehydria. Between the ages of 60 and 70, 25% of the population have complete achalaehydria. Above 70 years old, 30% have achalaehydria. So you can see that complete achalaehydria does not necessarily mean that the person is going to have pernicious anemia. The tubeless gastric analysis, unfortunately, has proved unreliable. Renal disease puts this test off. Gastric obstruction puts this test off. And similarly, diarrhea and malabsorption, a gastrectomy, and rapid gastric emptying time, which you cannot diagnose clinically, similarly put this test off. However, it can be a useful screening test, provided the quininium resin is used and not the Asia A resin. On the whole, if the bone marrow shows megaloblastic erythropoiesis, there is very little point in doing a gastric analysis. The reticulocyte count once again is being mentioned as a useful diagnostic test, and so it is. Some years ago, an Italian pathologist, Della Vida, constructed curves showing the expected reticulocyte response with a peak at 8 days following the institution of therapy in cases of pernicious anemia. These curves have been very useful indeed, and a reticulocyte count done daily for the first 12 days is a valuable confirmation of the clinical diagnosis. Coming to treatment, there is today no point in giving liver therapy. Liver therapy contains nothing that crystallized vitamin B12 does not contain. There is no added factors and there is no added advantage. In fact, the cost is greater than crystalline vitamin B12. Similarly, many people wonder about transfusions because many of these people present with very low hemoglobins. It is astonishing to me how well the cardiovascular system in these patients stands up to very low hemoglobin levels. I'm afraid I believe that as they have had these hemoglobin levels for a considerable period of time, there is very little value in rushing into blood transfusion therapy the minute they have entered hospital. However, when the hematocrit is below 15%, it is perhaps advisable to give 1 bottle only of packed cells to raise them to a level at which their cardiovascular systems will not be affected. Beyond that, it is not advisable to give blood transfusion therapy. Similarly, blunderbuss therapy, in the form of let us try this to see if it works, is not advisable. Because once one starts therapy, one has to continue for life. One can never stop vitamin B12 therapy. If one just institutes therapy on the basis of let us see if it will work, one is condemning many people with simple iron deficiency anemia to perpetual vitamin B12 therapy. The dosage of vitamin B12 today in treatment of classical cases of pernicious anemia is still a matter of debate. My personal preference is to give initial loading doses to the extent of 1,000 micrograms intramuscularly on alternative days for 5 doses. This leads to restoration of the liver stores of vitamin B12, and following this period I give maintenance therapy of approximately 250 micrograms once a month. Other people will have different opinions. Certainly, if there are marked neurological symptoms, one should err on the side of giving large doses. One should remember, however, that a large percentage of these doses above 250 micrograms are immediately excreted in the urine. At present, many firms are beginning to market oral preparations of B12 therapy. I would advise strongly against the use of these drugs. Resistance rapidly occurs due to the use in these preparations of hog intrinsic factor, to which the person becomes refractory. Experiments which you may have seen reported in the literature are underway at present using long-term gel forms of vitamin B12, and these look as if they are going to have success in the near future. Therefore, it is hopeful that within 2 years, long-term treatment will involve one injection every 6 months or so. However, these cases must be followed up in great detail because of the complication of carcinoma of the stomach which can develop. Similarly, one must keep an eye on these people because they may tend to give up their treatment on their own and then relapse, in which case their neurological symptoms may be worse than in the first case. Thank you for listening today.
The recording and distribution service for this presentation was made possible by the Wyeth Postgraduate Education Fund of the College of General Practice of Canada. You will now hear Dr. Robert E. Beamish of Winnipeg, Manitoba, speaking on impending myocardial infarctions, diagnosis and treatment. Dr. Beamish is a member of the Royal College of Physicians, London and Edinburgh. He is a Fellow of the American College of Physicians, American College of Cardiology, and of the Royal College of Physicians, Canada. Dr. Beamish also holds certification in internal medicine. Dr. Beamish is Associate Director of the Department of Electrocardiology at the Winnipeg General Hospital, Consultant in Cardiology and Electrocardiology to the Children's Hospital, and Consultant in Cardiology to Victoria Hospital of Winnipeg. Dr. Beamish also holds the position of Assistant Professor of Medicine at the University of Manitoba. Dr. Beamish.
Impending myocardial infarction, diagnosis and treatment. A major problem confronting the medical profession is the increasing prevalence of ischemic or arteriosclerotic heart disease with its attendant hazard of acute myocardial infarction. Although myocardial infarction may occur suddenly and without warning, it is now recognized that many attacks are preceded by premonitory pain. The reported incidence of such portentous symptoms usually varies from 30 to 50%, and the fatality rate in these series has ranged from 15 to 43%. Evidence is accumulating to suggest that prompt administration of anticoagulant drugs may reduce the incidence of myocardial infarction and sudden death in such patients who present with symptoms of impending infarction, or in what is sometimes called the pre-infarction state. Regarding diagnosis, recognition of impending infarction is primarily dependent on the occurrence of cardiac pain. There may be other symptoms which herald the approach of infarction, but no other has been found consistent or reliable. Careful analysis of the patient's pain therefore becomes the first major requirement for accuracy in clinical diagnosis. Premonitory pain is typical of cardiac ischemia in site, radiation, and quality, but it differs from classical angina of effort in that there is a crescendo in the occurrence of symptoms. The attacks are more prolonged, and there is an inconstant relation to effort. It is not strange that this bromal pain has been variously called coronary failure, acute coronary insufficiency, and intermediate coronary syndrome. Characteristically, A patient in normal or relatively good health suddenly finds himself unable to walk more than a few yards or blocks without pain, and may have prolonged pain at rest, especially at night, after food, or on lying flat. Nitroglycerin is still effective, but the requirement increases. There is no fever, leukocytosis, or elevation of sedimentation rate or of cardiac enzymes. The blood pressure does not fall. There is no pericardial rub or change in heart sounds, and the electrocardiogram shows only ischemic effects, or in fact may remain normal. Thus, there is no clinical or laboratory evidence of infraction. The pathological basis is variable, no doubt, but since the pain most commonly develops abruptly, it is reasonable to attribute it to coronary thrombosis, but without accompanying infraction. Dressler has stressed that myocardial infarction may present merely as angina pectoris of effort, but conversely, myocardial infarction is often preceded by an intensification of a previous angina of effort. As the basis of angina of effort is often an occlusion of one or more of the major branches of the coronary arteries, the sudden increase in symptoms usually means that there is a further narrowing or thrombosis in the remaining vessels. In a patient who has had a previous infarct and who has subsequently been pain-free, recurrence of pain is particularly ominous. In such patients with known coronary disease, a more or less abrupt recurrence of pain indicates further thrombosis. In this situation, it is reasonable to anticipate an increased incidence of myocardial infarction. From these considerations and from observations in patients, Beamish and Story have suggested that the pain of impending infraction has three common presentations to the doctor. Firstly, onset of ischemic cardiac pain in a patient previously free of symptoms. Usually the patient experiences repeated bouts of spontaneously occurring pain. These last from 15 to 30 minutes or longer, without clinical, cardiographic, or laboratory evidence of infraction. Less commonly, the pain may take the form of a rapidly progressive angina of effort. Whether the pain develops with the patient at rest or with exercise, it occurs oftener, lasts longer, and becomes more severe over the course of a few days or weeks. Secondly, intensification of angina of effort in a patient with previous angina for several months or years. Usually there is an abrupt change in the pattern of the chronic symptoms. Pain occurs oftener, with less provocation, lasts longer, and is more severe. Thirdly, recurrence of pain on slight provocation or at rest in a patient who has been pain-free ever since a previous myocardial infarction. Thus, when presented with the patient, the clinician must decide whether or not the pain is caused by cardiac ischemia or by something else. If it is ischemic, it is then necessary to ascertain whether infraction already exists. If it does not, and if the pattern of the pain is according to one of the three situations already described, impending infraction is likely. In making this diagnosis, the electrocardiogram may provide helpful confirmatory evidence. Changes consist of primary T-wave abnormalities or ST depressions. Such alterations are particularly helpful if cardiograms taken before the onset of pain are available for comparison. Serial electrocardiograms taken over a period of several days at the onset of treatment for impending infraction may show transitory but conclusive evidence of ischemia. It must, however, be stressed that the electrocardiographic findings are often normal and the clinical diagnosis must be adhered to even when there is no supporting cardiographic evidence. So much for the diagnosis, and now for the treatment or management. Despite its frequency and importance, little attention has been paid to impending infraction. Perhaps this lack of interest has, until recently, been occasioned by professional inability to alter the outcome in any significant degree. but now there is reason to believe that many infractions can be postponed or prevented. Since the responsible mechanism is inadequacy of the coronary circulation to meet the myocardial demand, it seems reasonable to place the patient at rest so that the demand is diminished. To begin, activity should be reduced to the amount that the patient can perform without symptoms. As a rule, this means bathroom privileges are allowed, although in occasional patients, complete bed rest may be required for a few days. Nitroglycerin should be used freely as required. Systematic mild sedation is indicated. While these traditional measures suffice in some instances, many patients nevertheless go on to develop infraction or go on to sudden death. Soon after the introduction of anticoagulants in the treatment of patients with acute myocardial infarction, several authors conjectured that these agents might well serve an important function in prevention of such attacks. Between 1949 and the end of 1961, Beamish and Story have diagnosed impending infraction in over 250 patients, but as a detailed analysis of only the first 220 patients has been completed, discussion must be limited at present to these. Commencing early in 1949, all patients whose original symptoms were in any of the three categories of threatened infraction which have been described, all patients were hospitalized and immediately anticoagulated. By December 1960, this diagnosis and treatment had been made in 220 consecutive patients. In 189 of the 220, the procedure was carried out according to recommendation. In the remaining 21 patients, it was not. The latter patients, therefore, serve as, quote, control, in quote, subjects. They are not perfect controls in that they are not alternate cases, but they compare in every way with the treated cases, with the exception that they did not receive anticoagulants. The reason that they were not so treated was that some of them did not feel they could take the time or go to the trouble of going into hospital, which was perhaps inconvenient for them at the time, and others had to remain on hospital waiting lists until serious consequences developed. More recently, anticoagulant treatment has been initiated in the home or the office, and heparin has been used in the more urgent cases. And now for the results. In assessing the effect of treatment of patients with impending infraction, it is necessary to take into account the duration of treatment and its relationship to the time at which symptoms first became manifest. Accordingly, the first 6 weeks after onset of symptoms have been arbitrarily considered to be the acute phase, the period from 7 weeks to 6 months, the chronic phase, and after that, the late phase. In the 21 so-called control patients, a disastrous mortality occurred in the first 6 weeks, during which 10 patients sustained infraction, 7 of them fatal, and 5 others died suddenly. In the chronic phase, 2 more patients succumbed to fatal infraction, and 1 more died suddenly. Of the 6 patients who have survived into the late phase, 2 of the early infractions are alive, 1 died in congestive failure, 1 died suddenly, and 2 have escaped infraction but have angina. In the 189 patients who were treated, 146 remained on long-term anticoagulant therapy, and 53 had their treatment interrupted for various reasons. Of the 146 patients on non-interrupted long-term therapy, 2 sustained myocardial infractions in the acute phase, while 3 died from infraction and 1 died a sudden death. While these figures are not subject to statistical analysis, nevertheless it appears significant that only 6 out of 146 treated patients, or 4.1%, were stricken, while 15 out of the 21 so-called control patients, or 71%, met a catastrophe during the acute phase. In the treated patients, some of whom have been on treatment up to 250 weeks, during the chronic phase there was one non-fatal and one fatal infarction and one death from another cause. In the late phase, 5 patients sustained non-fatal infractions, 5 suffered fatal infractions, 13 died suddenly, and 11 died of other causes. 2 of the infractions who survived were among the 5 heart failures. It would thus appear that anticoagulants exert their beneficial effect during the first 6 months following impending symptoms. There are some who may for a while be protected from outright occlusion, who could be labeled chronically impending, but eventually the atherosclerotic process is so severe and generalized that organic coronary occlusion is inevitable. The data derived from those whose therapy was interrupted substantiates the argument for anticoagulation. 53 patients interrupted treatment, 22 for reasons of hemorrhage, 9 for geographic reasons, 14 for miscellaneous reasons such as surgery, 5 because they were unreliable, and 3 had simply neglected their therapy for a few days and their prothrombin times were out of the therapeutic range. Of the 22 who were interrupted in the early phase, 2 had infarcts within 2 days of stopping therapy, 1 died of infarction in 10 days, and 1 died suddenly at 14 days. Of the 11 interrupted in the second phase, 1 survived his infarct at 2 weeks, 3 had fatal infarcts at 2 days, 2 months, and 6 months. 1 other death was due to a neoplasm. In the late phase, there were 3 sudden deaths, and 3 patients had infarcts varying from 2 days to 2.5 years. Of the 17 patients who infarcted or died, 52% were in difficulties within 2 weeks or less from the time of withdrawal of therapy. Again, the morbidity in comparable numbers is higher than in patients treated continuously, but not quite as severe as in untreated patients. To recapitulate, in the present series, the mortality in the first 6 months in the treated group was 2.7% compared to 42.8% in the so-called control group. Non-fatal infractions in the treated group were only 2%, whereas in the untreated group they were 14.2%. For statistical purposes, there should be equal numbers of treated and untreated subjects studied. Nevertheless, the benefit of anticoagulants in the acute and chronic phases appears substantial. Other investigators have made similar observations. Wood of London treated 33 patients with the result of 2 infarcts and no deaths. In his 25 untreated cases, there were 12 infarcts and 5 deaths. Nickel of Miami, Florida, reported a 6% mortality in 96 patients treated and 18% in 32 patients interrupting treatment. Maurice and others in Paris observed only 2 infractions in 71 patients treated, 8 fatalities when treatment was stopped. Newman in New York encountered no infractions or deaths in 17 treated patients, but with cessation of therapy, 9 infarcted and 6 died. The main disadvantage to the therapy is the complications, which are mainly due to hemorrhage. In this series, 74 patients had minor hemorrhages, mainly from the urinary tract, epistaxis, or ecchymoses. 26 patients had major hemorrhagic complications, and 4 of these led to death through cerebral hemorrhage. The number of hemorrhagic complications can be greatly reduced by the care with which the prothrombin time is watched. There is another point that I would like to make. If this treatment confers as much benefit as seems apparent from these figures, then it naturally follows that the treatment should be applied to as many as possible of the patients who have symptoms of impending infraction. Many patients of course, do not report to a doctor soon enough to get the benefit of such therapy. We have, therefore, over the years developed a program of education of patients whereby all patients with coronary disease are instructed to report to the physician any appreciable change in the behavior of their cardiac pain. In this way, more patients come under medical observation before they have progressed to the stage of actual infarction. There is, of course, a disadvantage in this, in that the physician is frequently informed of insignificant pains, but after a few discussions with patients, they soon learn which pains to report and which to ignore. The importance of this program is suggested by the fact that it took nearly 9 years to obtain the first 100 patients with impending infarction, whereas a second 100 patients was added within an additional 1 to 1.5 years. In summary, then, coronary thrombosis with myocardial infarction is a common condition with a high mortality. In many instances, premonitory symptoms give warning that myocardial infarction is threatening. It is suggested that these symptoms form a recognizable pattern which permits recognition of impending myocardial infarction with a high degree of accuracy. The common presentations of this syndrome have been described. Prompt administration of anticoagulants has been shown to influence the outcome favorably. In 220 patients with impending infarction, the mortality in the first 6 months in the treated group was 2.7%, whereas in 21 so-called control patients, the mortality in the same period was 42.8%. Non-fatal infarctions in the treated group were 2%, and in the untreated group, 14.2%. Long-term anticoagulant therapy is not without danger, as in any group of patients there will be minor and major hemorrhagic episodes, even though the therapy is under good control. The number of patients for whom this treatment is applicable can be extended by a program of patient education. It is hoped that this presentation has been sufficiently clear, but I am sure there must be some questions.
Yes, there is one question. What drugs were used as anticoagulants in your series?
Nearly all the common anticoagulant drugs were used. In cases in whom the symptoms were urgent, treatment was started with intravenous heparin in a dose of 50 to 100 milligrams intravenously to begin with, and 50 milligrams intravenously every 4 hours until the prothrombin time had come under control due to the simultaneous administration of oral anticoagulants. The oral anticoagulants used were mainly danolone or phenylendanedione, but Coumadin, dicumarol, tromexin, and Syntrome were used in some instances. We have found that danolone is very satisfactory because with sufficiently large doses, very prompt control of prothrombin time can be achieved. We ordinarily start with a dose of 3, 4, or 500 milligrams, and this usually results in the prothrombin time being under control in 24 to 36 hours. It is very important not to use these larger doses in patients who are over 65 years of age or who have any evidence of congestive heart failure.
Have you run into any difficulty with the use of anticoagulants in regards to aplastic anemias or leukopenias?
No, we have not. We ordinarily have avoided anticoagulants in patients who have any blood dyscrasia, particularly a severe anemia. We have not noticed any of the low white cell counts that have been reported in relation to the use of danolone.
Have you had any difficulties due to patients taking other medications while on anticoagulants?
Yes, we have. There are certain medications that increase the effect of anticoagulants, such as salicylates, butazolidine, and cortisone preparations. It is prudent to instruct patients who are on long-term anticoagulant therapy to refrain from taking any medications other than those which you have prescribed.
Do you recommend that patients on anticoagulants carry an identification card stating what drugs they are on?
Yes, I think this is a very wise procedure to follow. It is important that patients who are on anticoagulants carry a card or a letter outlining their treatment and dosage, and they should also, if they're going away from your area, carry a vial of vitamin K1 tablets with instructions to, first of all, call a doctor if they have any bleeding, but if a doctor is not available, to take 1 or 2 of the tablets pending the arrival of medical supervision.
The recording and distribution service for this presentation was made possible by the Wyeth Postgraduate Education Fund of the College of General Practice of Canada.